Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert insight from a webinar titled Hepatitis Delta in Focus, Answering the Questions on HDV Management, featuring Dr. Nancy Reau, Professor of Medicine, Chief of the Section of Hepatology, Associate Director of Solid Organ Transplantation, and Richard B. Capps Chair of Hepatology at Rush University Medical Center in Chicago, Illinois, and Dr. Heiner Wedemeyer, Professor and Chairman at the Hannover Medical School in Germany. For the full online educational program, including the Clinical Focus module, case-based blogs, resource guides, and downloadable slides, please visit the link in the show notes for this episode. Now let's get started and join Dr. Reau and Wedemeyer as they discuss hepatitis delta management.
Heiner and I are both really excited to have this conversation. So although there's going to be a very short didactic, most of this is really to address your questions and to talk about the really exciting forecast for hepatitis delta. So our guidelines are changing, but currently the American Association for the Study of Liver Disease recommends that only individuals that are flagged as high risk for hepatitis D be screened. And that would be individuals who are Hep B surface antigen positive and that have other characteristics. So hepatitis B presence is a mandatory one. And other characteristics would include demographics, such as individuals born in Africa or raised in Africa, Asia, the Middle East, Eastern Europe, South America, and the Amazonian basin, or other places, such as Greenland. And then high-risk behaviors, such as injection drug use, MSM, or men who have sex with men, individuals who are infected with hepatitis C or HIV because of shared transmission, those that have multiple sexual partners or history of sexually transmitted diseases, and then individuals with elevated ALT and AST and low and undetectable hepatitis B, implying that they have a disease that's active, but it is not their hepatitis B. And if you fall into any of these categories, there's an algorithm for evaluation, and you can see that in those that are surface antigen positive, the next test would be an anti-hepatitis D. If that antibody is positive, then you need to obtain a hepatitis D RNA to look for viral replication, very similar to how we would assess someone for hepatitis C. The screening study is not enough. And if the RNA is positive, then you're going to assess that individual for staging, so elastography or FIB4 or APRI to get a sense of their underlying liver health, and then looking for markers of complications such as ultrasonography to make sure that they don't have liver cancer. And then you might even consider a liver biopsy, and we can ask Heiner what his opinions are on that, because we do recognize that this is a very aggressive component or infection, and that these individuals might have more advanced disease at an earlier time point, and sometimes our non-invasive tools are less than ideal. Now, if the RNA is negative, at this point, the emphasis is on management of the hepatitis B. And if your hepatitis B is not active, but the ALT is elevated, then you want to consider alternative options. All right. I think a lot of the excitement, though, really comes around our treatment options, and I'm going to turn that over to Dr. Wedemeyer.
Thank you very much, Nancy. It's great having this discussion with you. And thank you all for listening on hepatitis delta. One word up front. So I'm always quoting the hepatitis virus alphabet, and D stands definitely for devil. And Nancy mentioned that Delta may cause significant disease, morbidity, mortality. And then obviously the question is, what can we do? So how to address this? Which treatment options do we have for this definitely most severe form of viral hepatitis? And I see in the questions that Sadiq Memom is already raising some questions around treatment, but let's first start. What do we have in our hands right now in summer 2023? So we have available agents. We have been using good old pegylated interferon alpha for the treatment of hepatitis D virus infection. There has been first attempts to treat HDV infection more than 4 decades ago with at that time conventional interferon, then later recombinant interferon, and then we performed also several trials investigating pegylated interferon alpha. You have to inject this immune modulator for once a week. And the treatment duration has been some matter of debate. The guidelines state that 1 year of treatment should be the basis. We explored in a large international trial in Germany, Romania, Turkey, and Greece, also 2 years of treatment, 96 weeks, showing that this does not really improve response rates. However, in single cases, even extended treatment has been performed with pegylated interferon. There was one trial performed at the NIH liver diseases section where they treated some patients for up to 5 years. And there has been a famous case by Reau published 20 years ago. So where a patient was treated, I think, for more than 10 years. And they finally then both HBV and HDV were cured in that patient. But that's what we have. The problem is with interferon that maybe only 10 to 20% really patients show long-term suppression of delta replication. And the other point is what we have to keep in mind, even if you respond during treatment and show an off-treatment response after 24 weeks, this may not be an SVR as we've been used to in hepatitis C treatment, because even late treatment relapses have been reported. In Europe, and I'm working in Germany, we have the privilege that we can use bulevirtide, which is a novel entry inhibitor, a concept that was developed by a virologist, Stefan Urban. That drug has been approved in summer 2020 by the European Medical Agency. This is an entry inhibitor. We have to inject the drug once daily as a sub-Q injection. We don't know yet how long to treat. We may ask, we discussed this with Nancy during the upcoming questions. At this stage, if I start treatment, this is maybe maintenance treatment for the majority of treatments. With bulevirtide, we have response rates after 1 year of treatment, so 3 out of 4 patients, so at least a 2-log decline in delta viral loads, more than half of the patients. Normalize liver enzymes, but maybe not every patient is responding. And as I mentioned, it's at this stage, the treatment duration has not been defined. And therefore, it's important that we have investigational agents in development, which is really good for the patients. There's a drug called lonafanib, a prenylation inhibitor, which is an oral drug. It's given 50 milligram BID. It's boosted with ritonavir. And the largest trial ever in hepatitis D virus infection has been performed with this drug. More than 400 patients have been treated in the DELIVER trial. And we're excited to see and to discuss the data of this phase 3 trial during the upcoming International Liver Congress in Vienna. The data are preliminary available on the website of the sponsor, so we can see that some patients are indeed showing a nice decline in viral load. Not every patient, but again, final data will be discussed in Vienna. And then there are other agents in development, for example, pegylated interferon lambda. We just could read a hepatology paper published in February, a phase 2 trial where this alternative interferon has been tested in a trial performed in Israel, Pakistan, and New Zealand. And in that trial, also similar efficacy as interferon alpha has been demonstrated. And the advantage of interferon lambda may be that there should be less systemic side effects because of receptor expression, mainly on endothelial cells, and therefore effects should be in the liver, but you should have less systemic side effects. There's even a trial has been performed again at the NIH combining lonafanib with interferon lambda. Also interesting data, and other drugs are in development, for example, siRNAs targeting the hepatitis B surface antigen. So I talked a lot about treatment, Nancy, but just to highlight that there are new drugs in development. We have some established treatments, but now maybe it's on us to discuss some of the questions around treatment that may arise. Feel free. Exciting times for Delta, I have to say, Nancy. Would you agree?
Absolutely. I think that anytime we hear something that talks about sterilizing or even functional cure of hepatitis B, you know that there's going to be some role for Delta. And I think that the hepatitis B enthusiasm is we're seeing some of these agents that are looking more and more realistic. And looking forward to the European Congress, because we always get a lot more information there. So I think some of our first questions actually talk about the care cascade. And I will open this up a little bit to you, Heiner. So one of the very first questions is, what do you do when the hepatitis D RNA is low? It doesn't imply negative, but low, but the patient has significant fibrosis. And maybe before you address that, I would like to ask you what your confidence is when we're looking at these non-invasive tools, that you even know if your patient has F4 fibrosis or not. In my own personal belief, if the non-invasive tool says my patient has advanced disease, I do believe that. However, I think I get a little insecure when they say that the patient's low risk, but I think that we understage some of these patients. What do you think, Heiner?
Absolutely, I agree. I think we have to distinguish for this very good question, asked by Sadiq. There are two different issues. The one is, can we trust, as you mentioned, fibrosis staging? And the question would be here, this has been based on what method? Is this really histology or some non-invasive issues? The other thing is HDV RNA. So that's really a critical point because we are used in HBV, HCV, HIV. We give viral loads. We have strict guidelines that, for example, hepatitis B virus infection above 2,000 international units, we should think about treatment. So we trust these numbers. My message to everyone here would be, don't trust numbers in Delta. Yes, we have a WHO standard for HDV RNA quantification, but there are differences between assays, and even in the hand of experienced labs, you may get with the same assay different quantitative values. I don't want to discuss technical details, but Delta quantification is dependent not only on the amplification of RNA, but it starts even with extraction. There has been studies showing that extraction of RNA, whether I do it manual or with different machines, lead to completely different results. So in this case, and the question, low RNA, below 500, but fibrosis, I first would ask which assay has been used to quantitate Delta, and then maybe even to be on the safe side, even if I then consider treatment, whether really this viral load 500 is really true, or whether with another assay, you may get higher viral loads. So Nancy, I don't know whether you can, in the US, whether you send, then if you are unsure, you send your sample for RNA quantification to a commercial lab or to CDC. What do you do when would you have this patient and would look for another RNA assay?
Historically, we needed to either send it to the CDC or NIH or another lab that had investigational platform. Now, LabCorp and Quest are able to supply Delta RNA, but I do agree with you that even in these commercial labs, we worry about the reliability. And I think that's really important, especially in a question like this, where you might have a patient who is at high risk from a fibrosis standpoint, but you don't think that their Delta is active. That repeating the test might be the first place to start, because sometimes it might be negative and now it might be positive.
Yeah, I agree. And then the other issue is F4. And in your introductory cascade of diagnostics, you mentioned the role of biopsies. Here, and again, Chris Koh and Theo Heller from the NIH, they published a paper evaluating non-invasive fibrosis tests that we use for different liver diseases, FIB4, or APRI or other scores. They don't work well in Delta. I still biopsy a lot of my patients, but not only to really be sure about staging of liver disease, but also to exclude features of autoimmune hepatitis, which you may detect more often in Delta patients than in other viral infections of the liver. So Delta has been associated with some kind of autoimmune phenomena. And this may become relevant because if you want to treat your patients with pegylated interferon, obviously autoimmune hepatitis may worsen. And therefore, before I torture a patient with interferon, I really want to make sure that I do not harm my patient. And therefore, I biopsy many patients where I'm not sure about staging and which I at least consider for interferon-based treatment. But on the other hand, if you have clear clinical signs of advanced liver disease, so thrombocytopenia, if you have a clear picture by ultrasound, then this may not 100% be needed to biopsy the patient. But and then finally, to answer this question, so what would I do if I have a patient with low viral load and would have evidence of compensated liver cirrhosis? I would treat this patient. And I would discuss this in Germany with my options, interferon versus bulevirtide. But I think this patient needs antiviral therapy. Even if viral load would be low, something is detectable, liver cirrhosis, after having excluded other causes of cirrhosis, I would consider this patient as a treatment candidate. Would you agree, Nancy?
Absolutely. And I think that your treatment options, I'm a little bit jealous of in the United States. We are looking at clinical trials, compassionate use agents, which are sometimes hard to get access to, and then the hope that we'll have bulevirtide approved and maybe lonafarnib approved at some point. But right now we are still using some old tools. And Heiner, you described like a flashback, right? Because prior to DAA therapy, when we had autoimmune overlap with hepatitis C, we would sometimes give prednisone in order to calm the autoimmune component before then giving interferon to treat the hepatitis C. Now, that has no role in Delta and no role in current hepatitis C management. But this is the time when you need histology to really fully clarify the patient in front of you. I might use MR elastography, which I think is a little more accurate, not necessarily well validated for Delta, but probably a little more accurate than our other tools if I'm only worried about fibrosis. But if I'm worried about more than fibrosis, you're going to go back to that biopsy, as much as we don't like to put our patients through biopsies.
I completely agree. And I think MR-based staging of liver disease is a good option. You may argue, yes, you cannot do this in every patient, but we are talking here about an orphan disease. We are talking about a very severe viral hepatitis. And therefore, I think there are not too many patients, but in these patients, we really should try everything to do our, let's say, homework as hepatologists. So appropriate staging of liver disease, I think, is really important. I completely agree.
Now, there is a very interesting question about, I think that Thor gave us, about how do you manage the patient who is Delta antibody positive, but PCR negative? Because our nice little clinical care cascade, ends in, if the ALT is elevated, think of something else. If it's not elevated, think about your Hep B. But that may not be true, right? We don't fully understand the dynamic nature of Delta. And Heiner, I think that our pegylated interferon data gives us some insecurity here. Wouldn't you agree?
Absolutely. The question, antibody positive, RNA undetectable. Yes, there are maybe, if you're in a cross-sectional studies, 1/3 of antibody positive patients are indeed undetectable for HDV RNA. So the question is, what is it? Is it cured Delta? You don't have to take care. Or is it a transient, let's say, control, and this may fluctuate? Or, and we discussed this before, is there a third option that your assay may have missed HDV RNA? 5 years ago, 10 years ago, the third option was reality in many parts of the world, because the assays were, let's say, not necessarily covering all HDV genotypes. And for those of you not so much in the Delta business, we have at least 8 different HDV genotypes worldwide. In some parts of sub-Saharan Africa, you have genotype 5, 6, 7, 8. They're quite distant to our genotype 1, which we have mainly in Europe and also in North America. So some of the old assays missed these rare genotypes. That was one issue. The good thing is, and Nancy mentioned some of the commercial assays which are now available, they should detect all HDV genotypes. So let's say the third option, that an assay is missing really rare HDV genotypes, I don't consider anymore as very realistic. So the second point may be an issue, and that is fluctuating courses during the natural history of HDV infection. So transient undetectability, and then the virus may come up a couple of months later. And therefore, my statement to my fellows in the clinic is, if you have a Delta patient, Delta antibody positive, RNA negative, call these patients back. You have to see them after 3, 6, 12 months, depending on the disease activity, on the individual history. But don't tell the patient, so you're cured Delta, this is just an antibody phenomenon, you don't have to care about this. So that would be my answer. So the option retesting is critical. You agree?
Yes, especially if your liver enzymes are elevated. So in the United States, we often blame that on fatty liver disease or medications, but you don't want to just take one test and dismiss Delta. And I'd also, remind the audience that these surface antigen positive patients do still require liver cancer screening. So even if you feel their Delta is not the problem, you can't just send them away. You have to continue to monitor them for other things, which should require intermittent lab testing. And if you see their enzymes go up or they're clinically advancing, even when you think their viruses should be quiescent, that's another time to rethink about whether your Delta might be active.
And it's important to note in this context, you mentioned cancer, which I think is very important. So being HBs antigen positive per se is a risk for developing liver cancer. And then there has been quite some debate to what extent Delta is adding to this risk to developing cancer. So is it only that Delta causes, let's say, more frequent cirrhosis, and then you have your usual risk of cirrhotic patients developing liver cancer? There is some evidence that Delta per se may even further increase the risk to develop liver cancer. There have been some quite interesting systematic reviews published from Switzerland and from Sweden, and they identified that in particular in Asian populations, Delta may add a significant risk for liver cancer and also in HIV co-infected patients. So again, even more highlighting that Delta is the devil, and we should really do not forget liver cancer screening. So your anti-HDV positive patient needs to be followed. That's a clear message.
So, Heiner, what do you tell your patients about liver cancer screening? So the American guidelines are a little gray. They say that Delta patients should be screened for HCC, but they don't actually tell you when you should start. And they don't say that it's different than the rules for hepatitis B, although we can interpret them to say as soon as you know you have Delta, you should start liver cancer screening. Maybe the new European guidelines, as they're anticipated, might address that. But I think it's hard now to come up with a clear plan.
Yeah, for hepatitis B, we have so many non-invasive, or we have scores, PAGE-B, CAGE-B, during tenofovir or entecavir treatment, yes or no. So we have many scores which may guide us whether I screen my patient every 6 months or only yearly, or whether, let's say, no regular screening is necessary. These scores do not exist, quite frankly, for Delta. And there's also not, let's say, a very large database that can really guide you how often to screen. I do my homework. I see my patient. If the patient has liver cirrhosis, I screen him at least every 6 months. There's no doubt. If I really have excluded liver cirrhosis, if the patient is doing fine, if the patient has cured Delta, even spontaneously or after treatment based, and then I may extend this to every 12 months. But what is even more important in this context, this is, let's say, my guidelines or what I tell my fellows. You mentioned in your introduction that many of the Delta patients were actually not born here for you in the US, or in my case in Germany. They migrated to our countries. There are a lot of cultural barriers. You really need to take your patient, you need to spend time, you need to explain them the importance of continued care. And I think this is, to me, one of the biggest issues in Delta, that it's not only doing good, let's say, standard medicine, but really taking care of your patient. And this includes explain the patient that they need to come back for screening.
Absolutely. So Rena submitted an interesting question, and maybe we can make it even a little less complicated than what she stated. So she has a patient who is co-infected with HIV, hepatitis B, and Delta with detectable viral load, high viral load, she states, cirrhosis, and a history of decompensation. And she is asking you what to treat this patient with. So I think irrespective of all the co-infections, or the HIV co-infection, a person who has a history of decompensation is going to be a very cautionary tale around pegylated interferon. And I would imagine lambda. Would you feel the same way?
Could be an option. So first of all, HIV co-infection, most important point is obviously, hopefully this HIV co-infection or HIV is being treated. And then obviously this must contain tenofovir-based therapy. So I think that's critical, that you control the underlying hepatitis B virus infection in this patient. But then this questioning or to do this in a patient with a history of decompensation. This is obviously a very challenging situation, the history of decompensation, because their pegylated interferon alpha may be problematic. Lambda in the future in patients with decompensated liver disease, I don't know. So this will not be an option during the next 3, 4, 5 years. And therefore, this patient needs to be followed closely. Very unfortunately, at this stage, the best option for this patient, if this would be recompensated now, would be bulevirtide only. That would be my option. And otherwise, if this is not available, you have to watch the patient, and then liver transplantation in the very end is the only treatment option if patients are decompensated or they have been recently decompensated.
We do have a path to try to get bulevirtide on compassionate use in the United States. I don't know how easy that is, since we also hope to have approval at some point. But this is not going to be a good candidate for interferon-based treatment.
Let me highlight one point, because obviously, and you mentioned before that we have been used to, let's say, association between autoimmune hepatitis and pegylated interferon treatment. That shows me, very unfortunately, how long we are in the field already. We are getting old. Sorry for that. The young guys cannot imagine what we've been doing a couple of years or decades ago. But what is important at that time, we have been treating hepatitis C borderline compensated patients with interferon. We managed. Even if a patient had 50,000 platelets, these patients could be exposed to pegylated interferon, and we could manage that there was a slight decompensation. Don't do this in Delta. So do not treat a patient with 30, 40, 50,000 platelets with pegylated interferon alpha. The risk for decompensation, in my experience, is much higher. And 15 years ago, I lost patients where I just tried to treat this borderline patient. So I'm really skeptical if in these borderline compensated. So we are, in the end, left with bulevirtide. However, bulevirtide is approved in Europe only in patients with compensated liver disease. So I don't know, Nancy, if you have a patient with 50,000, 60,000 platelets, portal hypertension, formerly still child A in the US. So if you would get access now to bulevirtide, would you treat him with bulevirtide, or would you say it's too advanced, we just list him for transplant? It's a challenging case, obviously.
Yeah, I mean, in the United States, it's we still have access issues for transplant. Now, it might be a little different if you had a living donor option, but if you don't have a living donor option, or your center doesn't have that option, then you don't want to promise someone a transplant if they have a low MELD score, because you're not going to have access to a transplant. And you don't want to give something off label. And so using bulevirtide in a decompensated patient when it's not approved for that is technically off label. But I would probably make the case to try with careful observation, because there is some anecdotal data suggesting that it might recompensate, improve portal hypertension, lead to decreased portal hypertensive gradients. So I think you have less to lose on that as long as you have a good, candid conversation with the patient in front of you.
I completely agree. And there is data from Pietro Lambertico in Milan. He was treating formerly compensated patients, but with clinical signs of portal hypertension, so either low platelets or cirrhosis. And what is very important, let's say, to note that these patients responded well to bulevirtide virologically, which is not a surprise. But more importantly, he showed also that markers of portal hypertension improved, so platelets increased, and that other markers of liver function, albumin levels, also improved. So this is, I think, extremely important data in my view, and also exciting data. But again, one caveat: if you start these patients to treat with bulevirtide, these borderline patients, then you have to continue, because we don't know yet when to stop. So if you consider treatment in a borderline compensated patient with bulevirtide, be sure that you only start if you at least can guarantee that access to treatment should be available for the next years, because we don't have data yet when we know how or when to stop.
So Heiner, I'll ask you a question. What do you do with the B then? So let's say you have a patient who's hepatitis B DNA negative, and you have delta positive, and you're going to treat your delta patient with, let's say, bulevirtide, because you have that. Would you treat the B at the same time?
It's a question, and we will discuss probably still in 5 years. So in the clinical trials with bulevirtide, there have been, let's say, the first trial, which we published in Lancet ID in January, in the 202 trial, all patients were on tenofovir backbone. So you wanted to control hepatitis B before you treat your hepatitis D virus infection. While in the registration trial, which will appear very soon in a big journal, there were, I think, 2 out of 5 patients, 40%, were not treated with tenofovir or entecavir backbone treatment. And then there was some concern. So if a reduced HDV RNA, would then HBV DNA increase? Because we know there's this interactions between both viruses. One virus is dominant. If you reduce one with the other virus, then may increase. And this did not occur in patients there. So even the HBV DNA declined with bulevirtide treatment in patients not receiving tenofovir or entecavir, which I think is interesting, but by the mode of action with an entry inhibitor, maybe even to be expected. But to answer your question, our patients, the majority of hepatitis delta patients being treated with bulevirtide is on tenofovir backbone. However, if there is no liver cirrhosis, and if HBV DNA is rather low, tenofovir treatment may not necessarily 100% be required. So in patients with mild liver disease, low HBV DNA, not every patient really must be treated with tenofovir. I don't know what you feel. That's in reality, most patients get it.
Yeah, I think that in reality, most patients get it. And then you're also going to be afraid to stop it, even if you have your delta well controlled. I would also say that it's probably not a one size fits all. If we get lonafarnib approved, we may not feel confident that the same relationship between the two viruses is going to hold.
Yeah, I agree.
Well, I will ask another question that Sadiq submitted, and this is probably, I want you to look into your crystal ball. Yeah. So the question is really around something that all of us have, and that is, what is the natural history if you manage to have a 2-log reduction in your delta viral load, but you still have replication?
So I have now 2 hours to answer that question. So that's one step back. I mentioned in my introductory slides that there may be late relapses, very low level of viral loads after interferon treatment. So there's no SVR, but we also analyzed and published data on that these patients that had initially higher viral load, you treat them and they have a lower viral load, either 2-log decline or even more, they have a better clinical long-term outcome. So the improved clinical long-term outcome does not depend on complete undetectability of HDV RNA. Even a relative decline is sufficient. Old days, Patrizia Facci, she published in 2004 a long-term follow-up of her interferon trials in the 1990s. And in the end, it turned out that not every patient cured delta, but had a 2-log decline. And those guys who had a 2-log decline in the highest dose group had an improved clinical long-term outcome. And all retrospective data, single center analysis from France, from the UK, from Sweden, from Germany suggest that a relative response is translating into a better clinical long-term outcome. However, what is the optimal cutoff? How much HDV RNA decline is required? Is it 1 log, 2 log, 3 log? Is it a fixed level if you can determine this? I don't know, 100 units, 1,000 units, 10,000 units. This is something we don't know yet. So long answer to a short question, but I think any decline is good.
And to add to that, the composite endpoint of a decline and then ALT normalization. Now that's going to depend on your agent, right? We know that interferon, especially lambda, might increase ALT. But maybe if you're looking for a more durable response, would you feel more confident if the ALT normalized in addition to that 2-log decline, or if the ALT remained elevated? I think that we do like to see a decline. We don't have that magic threshold, whether it's 2 logs from the person's baseline, knowing that our tools are not particularly accurate, right? A 2-log decline could even be lab error as much as it could be a true decline in virus. But if you see an ALT normalization, I think you're going to feel better. But all of us that deal with viruses would much prefer no replication over some replication.
Absolutely. Therefore, I'd say the ideal endpoint for any treatment of Delta would be losing S. That would be obviously, as you mentioned in the beginning, that's a functional cure of hepatitis B should be the goal for Delta treatments. But there are many patients where this is difficult, where we will not be able to achieve this. And then obviously we have to focus on Delta RNA. Undetectability is best. But finally, we want to improve the clinical outcome. And as a hepatologist, I strongly believe in liver enzymes, and the normal liver enzymes are better than elevated liver enzymes. And therefore, let's say for bulevirtide, we've been discussing whether just yesterday in the clinic here. So we had a patient who really improved liver enzymes from 200 to 70. So he did not normalize, but virologically with bulevirtide, HDV RNA decline, maybe only a log or so. So no 2-log decline, no normalization of ALT, but improvement from 200 to 70. And therefore, of course, I will continue treatment in this patient. Would you consider a continued treatment, or what would be your approach in this patient?
I think that if I don't think it's reasonable to give 10 years of interferon-based therapy, as you were suggesting, as you said, that we did try in the past. But as long as the toxicity of the agent is low and the efficacy is high, I wouldn't see a reason to stop it. So I agree that I would be nervous and I would continue treatment. Yusuf is recommending a blast from the past for you here. He says, "Dear Heiner," he's talking about when we pulled out all kinds of tools to make our sick patients with portal hypertension look less sick through growth factors. So he's like, would you consider a strategy where you added things like erythropoietin, eltrombopag, these growth factors to make your patient tolerate interferon, at least from a bone marrow suppression or a tri-lineage standpoint? Is that a good strategy?
Yeah, thank you, Yusuf, for this question. And Nancy, what was it after publishing the eltrombopag trial in hepatitis C? I think so.
That was NIT, yes.
Yeah, it was NIT published in the New England Journal 2010 or so, 8 or 9. So short answer, I would not do this in Delta. Because as I mentioned before, so these borderline compensated patients, they may decompensate with interferon, then you really have a problem. Also considering that eltrombopag long-term therapy may be associated with a risk for portal vein thrombosis, which I consider as a serious threat as in Delta patients. So yes, you want to try everything for your patient, but don't start eltrombopag to correct thrombocytopenia to allow interferon treatment. I would not do this in Delta. Quite clear answer on that point.
I also think that you have to look at the efficacy of your agents, right? So when you are trying to use these growth factors, the implication is not that you're using bulevirtide, but they're using a pegylated interferon product. And although the efficacy is not 0, it is also not 100% or even 80%. And so I think if you're going to try to do something with this much potential toxicity and risk, you want to know that the benefit you're going to get is warranted. And this is, like we implied, we are old. We went through this with hepatitis C. I'm old. And there were many patients that we drug through hep C treatment only to find that they relapsed when you stopped treatment. And I don't know that whether it's the risk of a flare or just the risk of the toxicity of the treatment itself, that's a particularly good strategy.
Yeah, I completely agree. Nancy, Khan also asked now basically maybe the final point, the usual questions, patients, advanced fibrosis, cirrhosis, and he thinks that delta is driving progression of liver disease. So how are you currently treating this kind of patient?
Well, I'm looking woefully across the pond where you have more tools than I have. And we are fortunate because we do have clinical trials, not for decompensated patients, but that do still take compensated patients with cirrhosis. In a patient like this, I would talk about pegylated interferon. And if pegylated interferon was not an option and the patient we felt could safely wait for bulevirtide, we do expect this to be approved. And so I would do watchful waiting, not tell them to come back in a year, but to see them frequently to make sure they don't clinically change. We used to have compassionate use access, at least in theory, but it's a challenge to get through. And although I'm not sure when bulevirtide will be approved, I keep hoping that its approval is sooner than the approval for compassionate use. And so I unfortunately monitor these patients. Heiner's treating them, I'm sure. If you didn't have access to therapy, what would you do?
The same as you did. I think this was a very good answer. So for us, we can, let's say this patient needs treatment. He has advanced fibrosis, cirrhosis. You need to consider something. If you have interferon in your hands, you have to explore the possibility of treating this patient with interferon. I think that's quite clear in 2023 in summer. If you have bulevirtide available, then this would be an alternative. But then the question arises how long to treat this patient. And that's certainly something where we may have an answer in a couple of months or next year when we have the off-treatment results of the 301 registration trial exploring 2 versus 3 years of treatment, and then we can give a final answer. But at this stage, if you do not have bulevirtide, consider interferon, and if interferon is not possible, then a close monitoring.
Thank you very much to our faculty, and thank you for our listeners for joining in. Please be sure to check back for more episodes on important hepatitis topics. Thank you and have a great day.